Hi guys, welcome back. The topic we're gonna study now is paracetamol toxicity. One of the important decision maker here would be that should we go in for orthoptic liver transplantation or should we be going in for N-acetylcysteine, and this normogram helps us in achieving this. The individual who designed this was Rumac Matthew. So in the honor of the same individual, we have what is called as a Rumac Matthew line. And you will notice that I have deliberately highlighted in red color here two timelines, 4 hours and 8 hours, and two values of 100 microgram per ml and 200 microgram per ml. What I want you to remember is that if the values are at least the cutoffs that I mentioned, 100 at approximately 8 hours or 200 mics or higher at 4 hours, then the decision will be straight away to perform a orthoptic liver transplantation. Otherwise, if the values are on the lower range as compared to this, then we can go in for N-acetylcysteine. And the reason why we have shaded this particular area gray is because this is the time when intervention has to be done. In fact, here you will notice two lines. One is the dotted one and the second one is a jet black line. Something similar to what I can say is a partogram or partograph that you study in OBGY, alert line, action line, something like that, but a slightly different concept. You see, Rumac Matthew line determines, what are the levels beyond which survival will be really very, very difficult unless and until you go for a liver transplantation. But for our convenience, because we doctors would like to pick up the manifestations in the patient relatively earlier, the treatment line has deliberately been kept. The mathematical values with respect to treatment line have been kept approximately 25% lower as compared to what was determined on the Rumac Matthew line originally, primarily because we want some extra time so that we have that minimal window in which intervention can be done and the life of this patient can be saved. And lots of time these would be pediatric cases because paracetamol in strawberry flavor, a kid might consider that to be something, I would say, sweet, and he might drink it. Especially I'm talking about poor families where I have seen a child, because he doesn't get to eat sweets or mithai and stuff like that. So paracetamol is like ultra tasty for him, and the child drank up maybe one full bottle or two bottles, and the end result would be interventions in the form of the aspects that I've said. Let's have a look at what is the safe dose of paracetamol, because even in adult cases you would be getting phone call from your relative who's suffering from, let me say, dengue, or a relative who's having COVID-19 and the fever is not coming down with paracetamol 2 tablets, 3 tablets. So the person is asking you, sir, how much of paracetamol can I take per day? So the safe dose is approximately 3 grams per day for those people whose liver is perfectly fine, people like you and me. But if a person is a known alcoholic, if he specifies in the MCQ alcoholic patient, then obviously because alcohol would be having fatty liver, then alcoholic hepatitis, and then subsequently alcoholic cirrhosis. So we have deliberately kept the amount of paracetamol that can be given to these patients safely to be on the lower value, that is 2 grams per day. Then you will notice that lots of time paracetamol is available in combination with lots of opioids. Especially like if a person is having renal colic, ureteric colic, you might be prescribing tablets which will be having PCM plus opioids as well. Now the problem with opioids is dependence. So what happens is that because the person is having dependence, he might try to eat more number of tablets. As a result of it, he can develop paracetamol toxicity. He will obviously have an opioid overdosage, but he will also be simultaneously having a paracetamol toxicity. So to minimize the risk of paracetamol toxicity, I repeat my statement, what the government has decided is that when it comes to combinations of paracetamol with opioids, the maximum dose that is present in the tablet of paracetamol is 325 milligram. That means that even if somebody will eat all the 10 tablets in one strip, most of the time the strip would be having 10 tablets. Sometimes some companies might be manufacturing 15 for cost effectiveness. But even if somebody is taking 10, he would still be consuming 3 or approximately 3.25 grams. That would be pretty close to the safe range per se. So this decision has been taken by the Drug Controller of India or Federal Drug Authority in America, primarily to minimize the possibility of paracetamol toxicity. Primarily the reason behind that would be opioid dependence, because of which the person might consume more than one tablet simultaneously, or maybe if somebody wants to commit suicide, obviously there is no limit to the number of tablets a person might consume. But we are trying to here make it things relatively safer for our patients. That is why these mathematical values should be remembered. Next, what I say is again, I would say, MCQ wise important, in a sense that this figure could be mentioned in a question, that how much would be lethal. Then I want you to remember that if paracetamol more than 25 grams is consumed, that would be a pretty large amount. I would say something like 9 to 10 strips. That's when the person would have higher chances of fatality. If the amount of paracetamol, the usual one would be 10 to 15 grams in adult patient, this would definitely require hospitalization. You will continuously monitor the blood values of paracetamol, and corresponding to the time of ingestion, you on the basis of this normogram can take a decision. If the person falls to the left of the treatment line, it's only conservative management. If he falls to the right of the treatment line, intervention. Interventions are mainly two, and these cutoffs which are highlighted especially in red, 100 and 200 mic values at 4 hours and 8 hours respectively, is when you press on the alarm button and say that we wanna plan orthoptic liver transplantation in the patient. The antidote for management of this condition would be N-acetylcysteine. So another question that would come up would be that N-acetylcysteine should be administered within how much time of ingestion? Obviously, it should be as early as possible, considering the fact that the person in the normogram is fitting onto the right side of the treatment line. N-acetylcysteine, if indicated in a patient, the word is if indicated in a patient, should ideally be started within 8 hours of ingestion to minimize the damage. I'll also tell you the mechanism of action of how N-acetylcysteine will be working. But the point is, usually the upper limit of this has to be remembered from the perspective that on humanitarian grounds, I will not deny somebody a treatment just because the patient was brought to my hospital late, like they went to a district hospital or they went to a CHC, proper treatment was not available. Now they've come to your teaching hospital come medical college. So if a person comes late also, we will give N-acetylcysteine, and studies have shown that we might be having a reduction in the mortality. So that's, I mean, not only a humanitarian aspect, but even all-cause mortality has been shown to be reduced even if you are using it on the upper limit. So lower limit and upper limit both should be remembered. Ideally is within 8 hours of ingestion. If he says upper limit, up to 36 hours. Here two more mathematical values would come up, and you would definitely say, sir, so many values coming up, so let's just try to remember the information. Earlier I told you two values, 100 and 200 for decision for OLT, orthoptic liver transplantation. Now I'm telling you two another values, set of values, that is 300 micrograms and 150 micrograms. The denominator would be standard per ml. Then if the values are in excess of 300 micrograms at 4 hours of injection, this is just to explain to you that why the normogram is so critical to the management of this patient, and has been determined after so many studies that if the values are in excess of 300 mics, then the damage is definitely highly likely, which means that the treatment is definitely to be instituted. But on the other hand, if the values are less than 150 micrograms at 4 hours of ingestion, in those circumstances, the chances of damage is relatively less likely. Why this is important, guys, is primarily because you see, he may not straight away ask you regarding when would you press on the panic button and go for a liver transplantation. He might even ask you that, okay, when would you decide to give N-acetylcysteine? So one parameter is obviously duration, but second would be levels also, no? I repeat the fact, for N-acetylcysteine, it's not only about the duration component within how many hours, but even the blood values. No, if the blood values are going at 300 mics at 4 hours of ingestion, that definitely means the fact that damage will be very, very likely. So we will try our best for management of these patients. Let us now talk about the metabolism of paracetamol in the body, and I'll also describe how N-acetylcysteine will intervene in this case. You see, paracetamol will be metabolized in the following ways. One of them would be neutralization by cytochrome P450 system is phase 1, which would result in production of this compound by the name of NAPQI. I'll write the full form of that also, but at the moment I want you to remember that this toxic product to the hepatocytes in your and my body is neutralized by glutathione. So if we take paracetamol secondary to, let me say, dengue fever, or there is COVID-19 or any other situation when there's a high grade fever present, it's not coming down, even if we take more number of tablets, the glutathione stores in our body will be sufficient to neutralize this N-acetyl P-benzoquinone. In fact, I'll just quickly jot down the names also, because no big deal that in multiple choice questions, just to make it sound a little sophisticated, they might write it, that would be N-acetyl P-benzoquinone imine. The point to be understood is that this product can be neutralized. However, if a person is an alcoholic, then the glutathione stores will already be lesser. If this person is undergoing starvation, let me say he is a poor farmer and the crops failed and he's close on the verge of starvation related death, then starvation patient per se would also be having lesser stores of glutathione. So the ability to neutralize the product which is formed from paracetamol toxicity, that is N-acetyl P-benzoquinone amine, will be relatively lesser. Similarly, if a person is taking ATT, especially isoniazid plays a role. If a person is epileptic and is on barbiturates, these four components that I have mentioned here before you in color green are important from the exam perspective, because these are the conditions in which glutathione stores will already be lesser in the person, so they are more predisposed to drug-induced paracetamol toxicity. At the same juncture, I also want you to remember that when you give N-acetylcysteine to the patient, it generates glutathione. If you generate glutathione, you will be able to neutralize this product, and therefore the hepatotoxicity, at least the progression component of it, will substantially reduce. From the exam perspective, they will mainly ask you about the phase 1 component, that is NAPQI. Though for completion of the topic, I also need to talk about another method by which paracetamol is metabolized, that would be via conjugation. And there would be two steps here. One would be sulfate moiety being attached. The second one would be the traditional glucuronidation. The message is that paracetamol toxicity will be higher in the category that I mentioned in the green box. N-acetylcysteine works by replenishing glutathione, so you are in safe zone subsequently. And let us now look at how the disease will evolve in the person post ingestion. Within the first 4 to 12 hours, it will be predominantly GI complaints in the patient. So there would be substantial nausea, vomiting, abdominal pain. Like I said, the mother of this child, she went to work, and when she came back, she found that the child is excessively sleepy, and she found some empty bottles of paracetamol. Or an adult person, he had opioid dependence and he took overdoses of paracetamol and he's alcoholic also. Then the presentation is nausea, vomiting, abdominal pain, but soon shock ensues. Like in any toxicity, subsequently circulation will be affected, third spacing can occur, and manifestations of shock will occur. The person will deteriorate even further, and by the end of the first day, the features of fulminant hepatic failure will evolve. There are two manifestations of fulminant hepatic failure. One would be encephalopathy, and don't be under impression that it will only be 24 hours that encephalopathy will supervene. If the dose ingested is on the higher side, this encephalopathy can come earlier also, especially in those patients who are predisposed. Therefore, you could be having either encephalopathy or you could be having bleeding manifestations, that is coagulopathy, in which the prothrombin time of the patient will always be diminished. Not only there can be damage to the liver, but paracetamol toxicity can also contribute to damage to the kidney. So in the question, he can definitely ask you what will be the damage to the kidney. Well, it will affect the intrarenal hemodynamics. You very well know prostaglandins play a role in maintenance of glomerular filtration rate. So the person can end up with development of oliguria and urea. AKI can develop in the patient. Subsequently, there can be even development of damage to the heart of the patient. The damage to the heart, the myocardial injury, can contribute to pump failure. Biomarkers related to cardiac function can definitely be elevated, not to the level in myocardial infarction. I'm not saying that troponin I will show a doubling or a tripling or a 5 times elevation, but yes, I mean the biomarkers can be elevated, kidneys can be shutting down, and primary complaints of the patient will be related to the liver damage. So let us now look at the treatment algorithm that we will be using for management of these patients. Initially, we will be performing a gastric lavage. If a person is already having vomiting, then this step may even be bypassed, and most of the time I can say cases might even come to you late. So step 1 and step 2, though they are given in the textbook, they are not effective after half an hour of intake. I'll just put that on record here. Gastric lavage and cholestyramine, which is a sequestrant, are not documented to be effective in clinical studies after half an hour of intake. So we are assuming if a person comes very early, good. If not, then we straight away move on to the decision to go in for usage of N-acetylcysteine, which will replenish glutathione. N-acetylcysteine, as I've already sensitized you, can be started as early as within 8 hours of ingestion by the person. And at this juncture, it becomes important for me to jot down the fact that if the values are in excess of 100 and 200 micrograms at the following hours, then straight away a decision for transplantation will be done. The cutoff is 100 microgram at 8 hours or 200 micrograms at 4 hours when I'll plan a transplantation for the patient. If a person has already gone into fulminant hepatic failure, if it's already a presentation, then again a orthoptic liver transplantation would be started. Now, as Government of India has aggressively promoted Anemia Mukt Bharat program from PSM perspective, you're wondering why. I want to tell you that with Anemia Mukt Bharat, iron supplements are easily available in households, and therefore in pediatric age group, not only you could be having a paracetamol toxicity, but you could even be having iron toxicity. What I'll describe next before you after paracetamol toxicity topic is iron toxicity, which has now become the leading cause of poisoning in children less than 6 years. You see, most of these supplements, they are sweet, super sweet in fact, and therefore they might appear very tasty to children. Now let us compare what's going to happen to this particular child who would be having development of iron toxicity. So there are a couple of stages, and it's the sequence of the stages that I want you to remember. In fact, there are 5 of them. The first of them would be GI manifestations, obviously. So the child will be having nausea, vomiting, and in large number of cases you will notice that this iron will be causing damage to the mucosa of the intestine. So there will be even hemorrhagic manifestations along with the diarrhea component. So this child is having blood in the stools. I did not use the word dysentery because that's primarily used for an infective cause. So all I'm saying is bloody stools can be present in these patients, and secondary to this blood loss, even the child can have circulatory failure. The trick from the exam perspective that the examiner wants you to mess up with is that initially there is GI manifestations, then there is a latent phase, which I will write it as a deceptive phase. Why it is deceptive? Because at this point of time, you as a doctor and the parents will get a false sense as if the child is having some improvement. This deceptive phase occurs approximately 6 to 12 hours when the vomiting will stop and the diarrhea will stop. So it will appear to everybody that okay, now the worst is over, everything would be fine. But then subsequently the child will deteriorate into stage 3, in which metabolic acidosis will ensue. This metabolic acidosis will be so severe that it will also cause cardiac depression. I repeat the fact, acidosis is dangerous not only because of the fact that it can damage the blood-brain barrier, swelling in the brain, development of seizures, but it can even cause depression of the cardiac function. So at this particular point of time, there will be development of metabolic acidosis. One is the poison itself, that is iron excess causing damage to the entire circulation, damage to the blood vessels, damage to the cardiac circulation. So poor circulation explains the metabolic acidosis of this patient, and most of the deaths will occur at this point of time. So parents will be under an illusion that oh, our child was improving. What really happened? Suddenly the pH dropped from 7.3, 7.2, 7.1, the cardiac function depressed, and that resulted in development of metabolic acidosis. So if they say what is the most common cause of death in a person who is having iron toxicity, then the answer should be given as iron toxicity stage 3. Subsequently in stage 4 there would be damage to the liver. You can very well understand 2 profiles will evolve here. One would be bleeding, hemorrhage, coagulopathy. This would be over and above the blood loss in the stools. There could be blood epistaxis, there could be hematuria, there could be hematemesis, and there would be features of ammonia intoxication, encephalopathy, asterixis developing in the patient. Stage 5 is however rare. That's only if the treatment has been given. This would be a delayed phase in which there would be scarring of the gut, and most of the time these patients will end up with gastric outlet obstruction. So these are the stages with which iron toxicity will progress. And from the exam perspective, all I wanted to remember is that the initial stage is not a latent stage or latent phase of illness. Initial is GI manifestation, then is a latent phase, it is a deceptive phase. This gives a false impression to everybody, including you as a trained healthcare worker will also feel that okay, now the vomiting has stopped, so child should be better, loose motions and diarrhea has stopped, blood in the stools has stopped. stopped, he should be better, but he's deteriorating further, and then the cardiac malfunction ensues. And once there is a cardiogenic shock, I mean, whatever you do, even if you give inotropes, the chances of death of the patient will be substantially high. So because of the fact that majority of patients of iron toxicity come to you with the features of shock, so you will be initially using IV fluids, because initially it would be blood loss, so it would be hypovolemic shock, and then subsequently cardiac malfunction will intervene. Since there is shock, oxygen supplementation would be given to the patient. The textbook says that there is no role of activated charcoal, because the vomiting in this condition is so severe that I think logically also we should be allowing vomiting to occur on its own. So there is no role of ipecac, which is used or taught in forensic for management of poisonings to induce vomiting. I said the vomiting itself is so prominent, there is no need of ipecac, and there is no role of activated charcoal also, because most of the time the iron toxicity, in fact, I mean, the amount of iron that is ingested, the amount will be so much that activated charcoal will not be able to cause any substantial damage control. So what is the drug that we will be using in this case for binding to iron and reduce the toxicity? That would be deferoxamine. In fact, I would like you to listen to the discussion of hemochromatosis that I have discussed in comparison with Wilson disease in the liver section as well. So you will be more comfortable with this drug, and the main mechanism of action is we are trying to chelate the iron component. I mean, when would you be using deferoxamine? So if the values are more than 350 micrograms per deciliter, that is when this is used. This is gonna be when toxicity will develop. There's another cutoff given in the book that if the blood values of iron are more than 500 micrograms, even if there are no features of toxicity, in some cases there might be delayed manifestations. So he says, irrespective of the toxicity, whatever be the scenario, like at the moment the child has not gone into shock, you should still be giving deferoxamine to the patient. We do not have a normogram standardized for iron toxicity, and as I said, I mean, as countries are aggressively, like our country, anemia Mukt Bharat being promoted aggressively, iron supplements available in house, the incidence of this is definitely increasing. And if you work in a tertiary care hospital, you would have seen in your pediatric posting and internship poisonings coming with respect to iron toxicity as well. There is also an oral drug that is just for reference sake that I want to mention here, just from the pharmacological domain, and this drug is one that is primarily used in transfusion dependent patients of beta thalassemia. You see, beta thalassemia patients, they're given recurrent packed RBC, so they will develop secondary hemochromatosis. So if I'm using this molecule deferoxamine, this is an oral molecule which can be used to bind to iron and reduce the damage present here. To just set the record straight so that it does not cause a impression like I have mentioned this drug for management of iron toxicity, I just want to say this is chronic iron overload that I'm talking about. Chronic iron overload will be common in children greater than 2 years of age. These are thalassemia children, these are transfusion dependent children, and since they would be developing even bronze diabetes. You very well know that iron can damage the beta cells of pancreas, so you could be having bronzing of the skin, damage to the beta cells of pancreas, and development of type 1 diabetes mellitus. So to prevent that from happening, to prevent that bronze diabetes complication from coming up, I definitely can be using this oral drug that is deferoxamine, which is the chronic perspective of iron overloading in a patient. But if it is acute iron toxicity, then it's mainly fluid resuscitation, if required inotropes as well, and deferoxamine would be the mainstay of treatment, with cutoffs of initiation of treatment would be 350 mics. In these patients, chances of survival are lesser, I would say, as comparison to the previous toxicity that I talked about, paracetamol toxicity, because in paracetamol toxicity, one, we have more experience, we have standardized normograms, we have drugs which are readily available as compared to a preparation of iron chelator. So usually the mortality rates are lesser on paracetamol toxicity. I said the reasons being we are more experienced in handling it as compared to patients of iron toxicity. In iron toxicity, I think the only thing important is this aspect which has been asked in even the INI set, that he asked you to grade or he asked you to just arrange them in the correct order. So the only trick was he mentioned latent stage first, which is the first thought process that okay, nothing is going to happen, then suddenly GI manifestations, whereas in actuality it is first GI, then latent, then cardiovascular depression, then liver obviously gets affected, and then there would be, if the child is lucky, I mean a gastric outlet obstruction, which I would still say is something which the child has or the adult has really pulled it off very, very well. So these are the details, guys, that I would like you to remember for two important aspects: paracetamol and iron toxicity. Keep hammering, keep working, and I'm very, very sure all of you are gonna do just excellent.